Wonderful. Now, the next talk is the first talk in our CME series for this session this evening, and it will be presented by Jim Tsai and Jim Tsai's fellow, Levon Genderegian. Many of you know Jim, of course, who's active in New York State and New York City and has been active here in Connecticut at Yale. Jim is the president of the New York Eye and Ear Infirmary of Mount Sinai, the nation's first and longest operating specialty hospital, and he is system chair of the Department of Ophthalmology at the at the Carl Icahn School of Medicine at Mount Sinai, the ISMMS and Mount Sinai Health System, and he serves as the Delafield Rogers Professor of Ophthalmology at ISMMS. Prior to joining Mount Sinai, Jim was the Robert Young Professor and Chair here in Connecticut of the Department of Ophthalmology and Visual Science here at Yale University, and Chairman and Chief of Ophthalmology at Yale New Haven Hospital. He has also had a faculty appointment at Columbia prior to that as the Chief of the Glaucoma Division at Columbia University Physicians and Surgeons at the Harkness Eye Institute. He's the author of over 100 peer-reviewed scientific publications, 80 chapters, articles, and textbook contributions, and including the Oxford American Handbook of Ophthalmology and Medical Management of Glaucoma, which is now in its 4th edition, and has served on the editorial board of 9 medical journals. So Jim is really one of the most well-regarded international specialists in academic ophthalmology and glaucoma, and he'll be presenting with his fellow Levon Genderegian. Pardon me, Levon, it was difficult for me to pronounce your name. And Levon is now a glaucoma fellow with Jim at New York Eye and Ear Infirmary of Mount Sinai. Levon attended the University of Tennessee Health and Science Center and also completed his residency in ophthalmology at SUNY Downstate in Brooklyn. So Jim and Levon will be discussing myths in glaucoma, their own perspectives. Jim and Levon.
Thank you, Vince. And it's great to be part of the CSEP and NISOS CME program. I'm going to share my screen. And also, I want to thank Lev for his case tonight, because I think it'll be very interesting. I'm just going to start off with just some myths in glaucoma, and I'll go pretty quickly so that we'll have time for Lev's talk. This is my financial disclosure. I do serve on the scientific board of certain companies. None of the technology that I described tonight am I involved with financially, though I've gotten NIH grants to look at some of the technology. So these are my 5 myths in glaucoma care, and you may have your own myths, but the ones that I tend to focus on is that there's a myth that patients with significant visual loss are able to detect their visual field defects. There's also a myth that IOP is the only significant risk factor. The third myth is that my own patients, the patients I treat, demonstrate excellent medication adherence and compliance. A fourth myth has been that glaucoma tube shunt surgery should be reserved for patients with end-stage refractory glaucoma. And a fifth myth among the scientific community is that non-IOP lowering neuroprotection treatment is not possible. I do believe it's possible. The first myth, let's tackle this. I want to thank one of my colleagues from across the pond, Professor David Crabb from the University of London, for lending me some of his slides, and he's really worked on this area of research for decades. So we tend to think of glaucoma as black areas, that patients see the black area and the black tunnels. And if you look at a lot of our medical literature, it suggests that patients should be very easily be able to tell that they have glaucoma based on these pictorial diagrams. However, perception of visual field defects, as we know, is very complex. And 2 eyes fill in, so that when you have significant visual field defects in one eye alone, but the patient uses both eyes, the visual field defects fill in, and the patients have reasonable visual fields in some cases. So the visual system fills in gaps. So Professor Crabb asked, how does glaucoma look? If we ask patients what they perceive and their amount of visual loss, what do they see? You would be surprised that none of the patients reported a black tunnel or black parts. Very few patients reported a blurred tunnel. Most of the patients reported blurred parts or missing parts, or they were not even aware. These are patients with significant glaucoma. And the reason is, and what visual physiologists are starting to understand, is that the brain actually fills in the areas that are affected in glaucoma. That is, you don't see the black spots. What you tend to see, you tend to see parts of the background that are filled in and are missing a specific point. So if a clock on a wall is in a visual field scotoma, a patient will not report a dark spot on the clock. The patient will just report that they don't see a clock, they just see a blank wall. So that's why it's oftentimes very, very difficult. Also, what do patients see? Patients report more blurring, double vision, or missing. So actually, when patients do daily activities of living, such as golf or tennis, that may be helpful. And if they report that they're getting worse doing those activities, I'm as concerned about those subjective reports as maybe even an objective finding on visual field testing. So they notice their visual field when they're driving, when they're reading, when they're going downstairs, when they're walking. And we know that there are variability issues with standard perimetry. And we know that deeper defects vary more than shallow defects, and the peripheral defects that vary more than central defects. And remember, in early glaucoma, we tend to get more peripheral defects, but there may be patients with normal tension glaucoma that have a very early central defect. So you may want to make sure that you do occasionally central visual field testing. We know that there are 4 major photoreceptors. Did you know that there are over 20 different types of ganglion cells? As glaucoma specialists, we tend to focus on the P cells, the K cells, and the M cells, and they serve different types of visual function. When I was at Columbia, we got interested in more what we felt was less subjective visual function assessment. One of the technologies, which I will discuss today, I was involved as a co-investigator on an NIH-funded trial. I don't have any financial interests with the company. And the thought was, how can we use the technology that we use in brain EEG technology for glaucoma? This is the PI Van Zieman wearing an early prototype. And the overview is, if you put 3 scalp electrodes on a patient, ask them to look at a test object. You don't ask them to press a button. This is totally does not involve the patient doing anything, but just looking straight ahead. Can we measure their cortical activity? And what we're measuring is the cortical activity to layers 1 and 2 of the lateral geniculate nucleus, the M cells. There are 2 types of patterns, bright check patterns and dark check patterns. And so when I was at Yale in 2013, we had reported early success with a phase 1. So we proceeded with a phase 2 study along with UT Memphis and the University of Alabama, Birmingham. We knew that one of the challenges with these studies is they tended to have small patient sample sizes. Well, now in 2020, 2021, we do have this technology available. It's still primarily research, but we recently reported our findings at New York Eye and Ear with our research. And what you see on the diagram is that in a control subject, someone who doesn't have glaucoma, you can see the test points are very close to one another. There's a small circle of confidence. And so therefore the signal to noise ratio, the signal is much greater than 1, it's 3.6, versus someone with glaucoma where you can see they're scattered, the EEG findings sometimes are not as consistent. You can see the signal to noise ratio is less than 1 at 0.41. So the conclusion is that a patient with glaucoma with 20/20 vision doesn't have the same 20/20 vision as someone without glaucoma. Their contrast sensitivity is depressed, and therefore technologies such as ICVP can ferret those out. What's myth number 2? Myth number 2 is IOP is the only significant risk factor in determining glaucoma incidence and progression. And we always teach that current glaucoma treatment lowers IOP, whether you use medication, surgery, and MIGS. So no wonder sometimes the clinical outcome is variable. There are many studies that have been published now showing that there are vascular risk factors, and I've listed several of them: diabetes, hypertension, low perfusion pressure, and migraine. One that I've been more interested in recently is really the role of low perfusion pressure. Because some of our patients with normal pressure glaucoma, if you ask them, these tend to be the very thin, elderly women who have very low blood pressures. And you can see based on the Baltimore Eye Survey, Barbados Eye Study, Egmont UMART, Projector, if you have perfusion pressures, which is simply, think of diastolic blood pressure minus IOP. That's a quick way of calculating diastolic perfusion pressure. If it's less than 30 or less than 50 millimeters mercury, that increases the risk of glaucoma. Also, we know that cardiovascular factors play a role. Here's the Barbados Eye Study. I put the relative risk of some of the traditional risk factors such as age, family history, higher IOP, thinner central corneal thickness. Notice that if you tend to have a lower systolic blood pressure where it's not super high, you do have a decreased risk of developing glaucoma with a relative risk of 0.91. If you have very low diastolic blood pressures, your relative risk actually goes up to 2.6 for low mean perfusion pressures less than 40. And we also know, and here's a review paper we published when I was at Yale, that inflammation also plays an incredible role. So I just want you to understand that we may have to think of other risk factors more than IOP. Obviously, IOP is the only way we have been proven to prevent the progression of glaucoma, prevent even the occurrence of glaucoma, but we should keep these in mind as we do for future research studies. The third myth is my own patients demonstrate excellent medication adherence and compliance. I've been interested in this ever since I was a faculty member, assistant professor at Vanderbilt. And the challenge with glaucoma is we all know that the patients poorly perceive their visual loss. The therapy has oftentimes more immediate side effects than they can tell a benefit. The treatment prevents but does not reverse visual loss. You add the costs of chronic therapy and follow-up, and the fact that the average patient probably has 3 other chronic diseases for which they take 4 additional medications. And then you add upon top of that disparities in medical care and community outreach. No wonder this is a very challenging disease to treat. George Spaeth published a paper over 25 years ago, which I think said it best. In the long run, single drugs that do the work of more than one drug likely would enhance compliance. And we know that Rick gave a wonderful talk on some of the benefits of combination Rocklatan. And so as you can see, what George noticed is that in his patients on one medication, they were 50% adherent. But when we put them on multiple glaucoma medications, we know that that reduces their adherence, and therefore the patients are less likely sometimes to even refill their first medication. So that's why we try to limit the number of drops the patients are subjected to. We also at Vanderbilt looked at the barriers to adherence with medical therapy. We did a study where we found 71 distinct obstacles that made it difficult for patients to take their drops. A third of the reasons were what we called regimen factors. They were forgetful. The drops caused res eyes. The drops caused irritation. Only a third of the 3% of the factors were due to provider factors. That is, they didn't understand the reason to take their glaucoma medications. 16% were patient factors, which are arthritis, maybe some forgetfulness. At least half of the factors and reasons that patients find it difficult to take the drops are what we called situational or environmental. That is, they're away from home. They forgot their medications. They have competing activities. We had patients tell us that they felt guilty when loved ones went into the hospital, that they would worry about their adherence to their glaucoma medication. So very complicated, the reasons why patients find it difficult to adhere to therapy. The WHO has made this an important topic. And so they published this landmark white paper saying there are 5 determinants of adherence. Not only do we have to teach patients the importance and threat of the illness, the benefits and burdens of treatment, knowing what to do and how to do it, but we also have to think of any social and instrumental support and resources we can provide patients. The fourth myth is that glaucoma tube shunt surgery should be reserved for patients with end-stage refractory glaucoma. This is a slide I'd love to show to the residents. This is a patient that I did glaucoma tube shunt surgery almost 30 years ago when I was a resident at USC Doheny. This patient had a double plate Multino implant, as you can see. Here's one plate, here's the other. And so I've been interested in glaucoma tube shunts surgery since a resident. We published a retrospective series in 2006, and we looked at the Barvell and Ahmed glaucoma implants, and we saw no difference out to 4 years. I was delighted at Yale that one of the medical students decided to do a thesis on one of these prospective studies, and I got involved. Ike Ahmed was the international PI. These studies were done in Canada, the US, and Chile. We randomized approximately 238 patients to either Ahmed or Barbell surgery implant. And you can see that the Ahmeds lowered pressure, but not quite as good as the Barbells, a difference of about 3 millimeters of mercury. If you look at reasons for failure, the Ahmeds were more likely to fail at higher IOPs. But it's interesting, if you're worried about safety hypotony, the Ahmeds seem to have a statistically significant difference compared to the Barbell implants. Visual outcome in these 5-year follow-up was no different between the two groups. Patients started with a baseline vision of 2100, worsened one line to 2200 at 5 years. We pulled the data analysis with the ABC study, another study, and the results were comparable to each of the studies alone. That is, the failure rate seems to be higher with the Ahmeds. The need for de novo glaucoma surgery is higher with the Ahmeds, but the failure due to hypotony is much lower with the Ahmeds. The mean IOP does seem to favor the Barbells and even the mean glaucoma medications. So the conclusions with this study and these two studies is that both of them are effective treatments for refractory glaucoma, and we're starting to do them much earlier. I do them now even as primary surgery, and there's a primary TVT study that has shown that implants can be safe even done as primary glaucoma surgery. The Barbells seem to have a lower failure rate, lower mean IOP, and require fewer medications, but have a higher risk of hypotony. And device selection should probably balance patient factors and surgeon factors. My final myth, and I did a lot of this research at Yale, is that non-IOP lowering neuroprotection treatment is impossible. I'm just going to cover one segment, which is neuroprotection and neuroregeneration via drugs. Did you know that the CNS, which we were taught in medical school doesn't regenerate, does so because there's an active inhibitory process. So our brain actively inhibits regeneration through our lifetime. If we are somehow able to use some of these agents, we could either decrease neurodegeneration or even have neuroregeneration. One cytokine I studied at Columbia and Yale was EPO, erythropoietin. You know it because the athletes take it. EPO, when it binds to receptors on the retinal ganglion cells, actually causes this pathway, PI3 kinase, to inhibit apoptosis. At Columbia, we showed in rats that if you give it a single intravitreal dose of erythropoietin, guess what? You get a retardation of that loss of retinal ganglion cells that you see with the control. This is episcleral venous cautery, where we raised the IOP in rats. And so I did some follow-up studies. My AOS thesis was showing the safety of erythropoietin, EPO, based on ERG and histopathology. Also, we did some work with Lucien Del Priore, actually, at Columbia, looking at dose toxicity of intravitreal EPO in rabbits. Now, finally, at Yale, what I was interested in is why isn't there regeneration in the CNS? Steve Strittmatter, who's a professor at Yale, has done a lot of work. You can see that an axon growing in control median rapidly sprouts out, but something in CNS myelin inhibits neuroregeneration. And what we find is there is an active inhibitory process happening mediated by the NOGO receptor. And so at Yale, we first wanted to ensure that 99% of the retinal ganglion cells do in fact express the NOGO receptor. We generated this anti-NOGO receptor blocking protein, which kind of looks like an antibody. And we did some studies. And here's a study where we showed that in rats that either have elevated IOP, where you cause glaucoma, some glaucoma damage, or you transect the optic nerve, that if you give some of this no-go receptor blocking protein, you do seem to get this axonal growth post-treatment. I'm not saying this is ready for prime time. I think we have a lot more work to be done, but I do think that this area is ripe for the newer generation of vision scientists to work on. So in closing, I hope I've shared with you my 5 myths in glaucoma care. And this is my own opinion. And I'm going to turn it over to Lev, who will present the case study tonight. So Lev, let me stop sharing.
Okay, well, thanks so much for the opportunity to speak here. Happy to be here. And thanks for the interesting talks, Dr. Tsai and Dr. Lewis. So I'm going to share my screen here. Hold on just a second. Okay. Okay, so I'm going to present an interesting case here. This is actually a case that I dealt with right at the beginning of my fellowship, and I learned a lot. It was a pretty difficult case to deal with, and I hope you all find it interesting. So this is a case of a 32-year-old male with a history of aphakic glaucoma from an infantile cataract extraction. He had a trab at age 14, which had failed a long time ago. And the referral was for an IOP spike to 50 after a regmatogenous retinal detachment repair 3 weeks prior to the referral. And of note, his pressure was previously controlled on just COSOPT. And this was a unilateral case. His right eye was totally normal. So prior to referral, the referring service had placed an Ahmed valve 1 week prior to him being sent to us. And at that time, there was still some residual gas, which was SF6 from the retinal detachment repair. And per talking to the surgeon, they expelled all of the residual gas through the AC, and they placed the Ahmed valve through the pars. Patient did well for about 5 days, then came into the emergency room with pain and pressure to the 40s, which was then refractory to medical management. So he was then referred to us. So his exam was notable for count fingers vision in the left eye, pressure of 40, and an APD, which was noted to be long-standing. Slit lamp exam was notable for a completely normal exam in the right eye. And in the left eye, a flat old trabeculectomy bleb, superiotemporal Ahmed valve, which was well covered and well positioned. Pretty significant corneal edema, relatively quiet AC, aphakic, and advanced cupping. Of note, we were unable to visualize the tube in the vitreous cavity. So next, we decided to do a B scan just to visualize the Ahmed plate and see if there was any flow, and we did not appreciate any. So at this point, considering how to explain what was going on, our differential was primary Ahmed valve failure versus some kind of tube occlusion, whether that be from residual vitreous or gas, even though at that point it was unlikely there was any gas left in the eye, or something inflammatory. So at this point, we kind of conference with our retina colleagues and decided the best course of action was to take the patient back for emergency vitrectomy, just to kind of visualize the tube and possibly revise it. So our retina colleagues went in first and inspected the vitreous cavity and confirmed that there was no tube inside the eye. And really the crux of this case lies in this photo here. And I apologize, it's not the best photo, but this is the best image I could get from the case. This is actually during scleral depression, and you can see the light pipe kind of shining right at the pars plana, and this little that little kind of white bump that you see is actually where the tip of the tube is. So it's actually embedded in the ciliary body. So at this point, we decided to externalize the tube. We flushed it with balanced salt solution and confirmed patency. We actually noticed a really good bleb elevation over the plate. And just to be able to kind of visualize the tube adequately in post-operative exams, we decided to put it in the anterior chamber. The length really wasn't sufficient to visualize it easily in the vitreous cavity. And the patient didn't dilate well either. So the patient initially did well, and I wish I could say it was kind of smooth sailing after this, but that wasn't the case. He had a really aggressive hypertensive phase about 3 weeks after the revision, and the pressure remained in the 30s despite being on 4 different topical medications, Diamox, and despite multiple plate needling attempts. So about 2 months later, we eventually placed an inferonasal Barvelt, so a second tube. And unfortunately, he had a hypertensive phase after this, with the pressure remaining in the high 20s on drops and Diamox. So eventually, we finally were able to stabilize the pressure by doing transscleral CPC. And this has resulted in good IOP control for 6 months now. And most notably, the patient's vision has returned to his baseline of 20/40. And I didn't put the visual fields up here. He already had pretty advanced disease before the retinal detachment repair. And fortunately, he had very minor progression during all of this, but still it's been able to maintain useful vision. So, my take home points from this were, you always want to be 100% satisfied with your tube position. And that with that kind of goes, visualizing your tube tip, which is never really an issue in the anterior chamber, or at least usually not, but certainly can be if you're placing a pars plana tube or a sulcus tube. And then just at a more meta level, always just be prepared for a long kind of drawn out battle when it comes to dealing with these advanced glaucoma cases. But, ultimately we stuck with the patient, and he's now doing well and happy. So I just want to acknowledge my fellowship director and attending on the case, Dr. Kate Vinod, the retina attending on the case, Dr. Alexander Barash, the retina fellow on the case, Dr. Penhas, and of course, our patient. So thanks so much.
Thank you so much, Levon. And Jim, thanks so much for that wonderfully broad and comprehensive talk. We do have one question for both of you, or for Jim, actually. Jim, would you mind putting back up the slide of the 5 myths? One of our attendees.
Okay, let me just.
If you can, and if you can do that.
Okay,
and
if you could stop sharing, I can.
Yeah.
Okay.
The attendee wants to see the slide of the 5 myths, and if you could possibly in the next couple of minutes, if this is possible, to expand on your theory of neurodegeneration of ganglion cells.
Yeah, this is very controversial, and obviously this could be an entire symposium on this. But what we're understanding is that it was always taught in medical school, when I went to medical school, that the CNS doesn't regenerate. And that was taken as a fact, right? Peripheral axons regenerate. What I learned when I got to Yale and started talking to the neurologist there is that the reason why the CNS doesn't regenerate is that's an active inhibitory process. That there is an active inhibition going on through our lifetimes. And it kind of makes sense. You don't want your axons sprouting in response to any stressors. So what we're starting to do in animal studies is figuring out ways to coax these axons to regenerate in response to noxious stimuli by blocking this no-go receptor. And I think that there's a lot of folks that are starting to look at, you know, degeneration or stem cells. In fact, Bo Chen, who was at Yale and joined us at Mount Sinai, published a paper several years ago showing that if you start doing gene manipulation, and I didn't cover that, you can actually make blind mice see. You can take congenitally blind mice, and if you add 3 new gene products, they can start, their photoreceptors can start seeing. So I think we're a long way off, and I tell patients, the last thing I want to do is make it so that you regain your vision, but the ceiling appears on the floor. That would be a disaster. So I think this is going very slowly, but I don't want people to say it's not going to happen or it's impossible, because I do believe if we understand the science, we will come up with some innovative therapy. So that's a long-winded answer to say, it's possible, I believe, maybe not in my lifetime, but I see a lot of younger scientists, ophthalmologists, they want something to study for 30 years, and I try to get them interested in this field.
It's a great field to be interested in, and I'm a cornea person saying that to you guys about glaucoma. Jim, thank you so much. That was just a terrific talk. Levon, thank you so much for that complicated and very well managed case. I really appreciate both of you being here with us this evening. Thanks so much.
Thank you.
Thanks again. So we're going to move on now to the second talk in our CME series. You just heard the first talk in the CME series, and the second talk now will be given by Samuel Maskett and by Gregory Ogawa. So as that slide is coming up there, you see it, IOL exchange tips and tricks. Let me read you a brief summary of both of their bios. By the way, the full biographies of all of our speakers are on the CSEP website. I have put the CSEP website in several chat box, panel and attendee broadcasts. So you can just go to the chat box, you can find that. And actually, if you click on the URL, it'll take you right there where you can not only see the bios, but you can get your CME evaluation forms and obtain your CME credit. As I said at the beginning of the evening session back at 6 o'clock, that tonight we have an hour and a half of CME, and on Saturday, when Ed Lim will be moderating, we have 5.5 hours more, so you'll have a total of 7 hours. So let me introduce Sam and Greg. As many of you know, Sam Maskett is clinical professor of ophthalmology at the Geffen School of Medicine at UCLA and founding partner of Advanced Vision Care in Los Angeles. He has been on the board of trustees of the AAO, and he's another past president of the American Society of Cataract and Refractive Surgery, the ASCRS. He has served as an associate examiner for the American Board of Ophthalmology, has published over 100 articles, serves on the editorial boards of several medical journals, and has been the honoree and lecturer. He has given the Binkhorst Medal Lecture in 1998 and the Charles Kellman Memorial Lecture in 2013, as well as more recent lectures, the Lindstrom Lecture and the Alan Crandall Lecture for the late and sadly missed Alan Crandall. Currently, Sam is also chair of the AAO's Senior Ophthalmologist Committee, and he is deeply involved in research and clinical research related to complex cataract and lens-based surgery. And he and Barbara he and his spouse Barbara have embarked on a new venture, the Samuel and Barbara Maskett Foundation, whose mission is to provide anterior segment eye surgical care to the underserved, to train fellows and to support clinical research. Greg Ogawa, who will be speaking with Sam in a moment, specializes in complex anterior segment cornea and cataract surgery at Eye Associates of New Mexico. He's an associate clinical professor at the University of New Mexico and medical director of the New Mexico Lions Eye Bank. After undergraduate studies at Carleton College and medical school at the University of Rochester, residency at the Medical College of Wisconsin, and a cornea fellowship at Wilmer at Johns Hopkins in Baltimore. Greg has been a national and international visiting professor and lecturer at major ophthalmologic meetings and locally at the University of New Mexico. He serves on the ASCRS Challenging and Complicated Cataract Surgery Committee, and his other academic activities include presentations and developing new surgical techniques, as well as writing book chapters and articles. So without further ado, Sam and Greg, will tag team our CME talk, our next talk in our CME series, IOL exchange tips and tricks. Sam and Greg.
Thank you very much. I'm going to try and share my screen here. Is that viewable, the IOL exchange title slide?
We see it. Perfect.
Yes.
We hear
Yes.
you well.
Okay, very good. I'm going to thank you very much for inviting us and for having me do this. I'm going to start with some word slides. I'm going to move through relatively quickly. It looks like we're about 5 minutes off schedule, so I'll try and go through those quickly so we can get to some videos, and then Sam, of course, has interesting material for us as well. And okay, so no financial interests. Things a little, okay. So indications for IOL exchange, reposition, the dislocation, subluxation are somewhat obvious, but those happen in a variety of forms now. And inflammation, UGG syndrome with elevated pressures and CME, pigment dispersion. And then newer to the arena, when I say newer, I mean more the past decade and a half, dysphotopsias and poor quality of vision. And some of this is related to just more modern IOLs, and some is related to premium IOLs. The considerations for doing IOL exchange type surgery is you really need to keep the eye pressurized, minimize bleeding, maintain anatomy. And you have two main options. One is an infusion cannula, which for anterior segment surgeons should generally be through the limbus if there's an open lens capsule diaphragm. And then OVD can be used if it's intact. I personally find that I use 4-0 silk bridle sutures quite a bit, and some people may never have used them, but the taper point needle, they can really help stabilize the eye when you're doing a variety of acrobatics inside the eye. Choosing a good location for the main incision, see when they had previous cataract surgery, and from that you can either infer or look at the eye, see where the old incision was. You don't want to do a 20-minute surgery and a 20-minute eye closure because you chose poor tissue to go through. Main incision, if incisions are bigger than around 5 millimeters, I really think a scleral tunnel is the route to go to minimize astigmatism and corneal issues. And you talk about anesthesia, say, well, it's the obvious, but this middle option, topical with subconj, I find myself using a fair amount. So that's a patient I think the case length, the patient cooperation might work for topical, or even if I know it's not going to work for topical, put subconj, bupivacaine, marcaine with lidocaine mix, superiorly, inferiorly, use a muscle hook to massage that back. And I can put in rectus bridle sutures within a minute on that if need be, but it gives more comfort for the patients. And so I know Ike Ahmed says he does everything topically, but I think that must be with a propofol drip because he does some pretty extensive surgeries, but don't make it harder on yourself than you need to. Remember that when you're in this area, when doing regular cataract surgery, you prefer to not be dealing with vitreous, but a lot of IOL exchange type things, the dealing with vitreous might be the first thing. You don't want to be pulling on vitreous because, of course, that leads to retinal tears, which then can go to retinal detachments. And I remove like the front half, at least, of the vitreous from the vitreous cavity because I don't want vitreous later in the case coming up and have to deal with it again, additional traction issues. And remember, for actually removing vitreous, you do cut IA mode, which means that in foot position 2 on the pedal, is when you start the cutting, but you don't actually get aspiration until you get into position 3. But you want it to be cutting once you start aspirating. High cut rate just depends on what the machine is in terms of how quickly you can cut. And then low flow, moderately high vacuum. Sometimes you've got a dislocated IOL. It's still in front of the eye, but it's all wrapped in vitreous. So you can't just grab it and pull it out. So you can do a couple of things to stabilize it. One is using a chamber needle, curved chamber needle on polypropylene to go under a haptic or through capsule or even through acrylic optic or haptic material, or using intraocular forceps to just hold it in place while you remove the vitreous from around it. Have a good pupil size. You know, as we just talked about vitreous and all the rest, you want to see what you're doing. And really, for these kinds of cases, it means iris hooks. I know there's a lot of people who love using Malayugan rings and eye rings and so forth for cataract surgeries, but those don't make the pupil big enough, and they don't make it big enough. They don't give you the flexibility to make it bigger in some places than others. And removal of an existing IOL, if you've got an intact capsular bag, I'm using an angled, I'll show you a picture of it in a moment, angled tip 25 gauge capsule cannula on OVD, which you can elevate the end of your capsule, fill the capsular bag. And I keep the IOL in place so it acts as sort of as a valve to help maximally inflate the capsular bag. In getting that capsular bag inflated is how you make removal of the IOL easier. Sam's going to show us and talk to us a whole bunch more about getting the IOL out. So I'm not going to dwell on this at all, but and sometimes I'll show you a situation of this capsule support hooks. So they're not iris hooks, but capsule support hooks can be very useful when the haptic is fibrosed into the bag in a particular location. With a open posterior capsule, you often need to do vitrectomy first before you start trying to pull the IOL out. And removing the haptics can be more difficult in this situation. You may need to truncate the haptic and leave it in the periphery of the bag. Anterior chamber lenses, take the opportunity to use your gonio lens in the exam lane and look at the foot plates, see what you've got. Is this one that you'll be able to pop right out? Or is this one that most of the case will be getting the lens out? And you need to be very careful because angle vessels are fragile and bleed easily. So here's a picture of a photo of this beveled tip capsule cannula. I've got it turned sideways a little bit here. You can see some OVD coming out. And then here's a patient pre-op photos in the clinic. So supratemporal foot plate, it's in a good position. Supranasal looks pretty good. Infranasal, oh, we've got an oversized lens was placed. And this is a patient who the retina specialist sent to me saying, gosh, this CME is refractive to Ozurdex. Well, I'm looking at this and see why. And I thought that was the big reason. Then infratemporally, you can see that the haptic literally eroded all the way through the iris. The iris healed back together, and that foot plate sitting on the ciliary body. So having this, looking at this ahead of time, I knew where the challenges were going to be. And then also removing dangling IOLs, stabilization with the techniques as we talked about, sometimes the vitrectomy probe for lifting, and removing IOLs through small incision. Acrylic IOLs can be either cut inside the eye or refolded. Silicone IOLs are so slippery once they're wet that cutting is the only option. And I often, even if I don't need to cut it into 3 pieces, I try and stay away from the middle of IOLs just because it's the thickest part, harder to cut, more tiddlywinking potential. And remember that the IOL needs to come up to come out of the incision. So hooking with a straight instrument from the posterior side of a haptic to lift it up rather than trying to get it to come up by having an instrument on the top. Placement for new IOLs, bag placement's the best. That's and in my opinion, sulcus with posterior optic capture is the next best. 3-piece IOL. I think that a sticky acrylic optic material is best because it helps decrease the chance of it popping anterior again. You can get a really solid capture that way. Sulcus, people say sulcus all the time, but unless the eye is small, you're basically saying, I'm going to put it behind the iris and hope that the patient does okay. Because none of the IOLs made, at least in the US currently, have a large enough overall diameter to keep the lens stable. And so then you can get UGG from lens motility. Then there's scleral fixated. Remember, any scleral fixated needs a peripheral iridectomy to avoid reverse pupillary block. When a patient blinks, when they rub their eye, that's a fast, high volume motion pushing fluid posteriorly that can push the iris back behind the optic with any of these techniques. And so I do a couple of PAs, not the little PIs to prevent angle closure from aqueous rate production. These are a little bigger. Sutured 9-polypropylene may last a little longer than 10-0. Expanded polytetrafluoroethylene, EPTFE, which is Gore-Tex. CV8 is the smallest made. I'll list here that the packaging still says contraindicated, even though we've been using it for over a decade, and even the company is not aware of any issues. They just did not study it for eye use. And then intrascleral haptic fixation. There's the glued IOL that was in vogue a few years ago. Short-term data, not that great. Long-term, not readily available. The technique by Professor Shin Yamane with melted tips is very popular right now, but even his data, he does not have actual long-term data. Here's a poster from 9-0 polypropylene, over a 10.5-year average follow-up of 202 eyes that a few of us presented at the Academy a couple of years ago. And we really had great results, but it has the large 1-piece PMA lens, which people that you can see pictured over here. And so that's not new, trendy, or small, but we get really good results with that. Then sulcus position IOL with the haptic suture to the iris, it's reasonable. You really, in my opinion, need to have good capsule support. Otherwise, it causes inflammation from tugging on the iris. And I have to say, even though I do a ton of IOL stuff, I only do this a couple times a year. And then ACIOLs, it's been a while since I've done one. If you do, remember to make a PI for pupillary block. And for me, there are multiple relative contraindications, which includes almost all the patients that I do surgery for. The iris claw type IOLs are available in the US, but not in the aphakic version. So that's not really an option for us here. Excuse me. So this is a video here of IOL stabilization. So here's iris hooks to make the pupil bigger. So this IOL, it looked tenuous to me over there. So put a straight IOL manipulator underneath it. And this is a CTC 6L needle. There's vitrectomy that needed to be done, but I wanted to have I didn't want to have to be calling my retina colleague to say, guess what's on the optic nerve. So here's the sharp tip keratome going through enlargement keratome. Watch the IOL here as I start to enlarge this to the 7mm width for the new lens I'm going to put in. There we go. So that would have disappeared, but instead I've got it on the, got it on the needle, and you can see here, I'll focus, you can see it's right on top there. And so taking this out, this pair of IOL grasping forceps, and then used a cyclodialysis spatula here, or actually an IOL manipulator to flip it up and bring it out. And so I'll go to the next one here. Yeah. And so this is an example. I was talking about using an capsule support hook to help with getting a stuck haptic tip out. And so, I put viscoelastic around that area, pulling. I can see the capsule equator starting to come a little bit. So this type of capsule support hook, that's not the broader sort, but this narrower tip where you can get focal support of the capsule. You can watch it. This has changed nothing except putting that hook in, and you can see the capsule stays in place and the haptic just drifts right out. And here, so this is a lens that was put in the sulcus. Patient had inflammation issues and pigment dispersion, because look how nice and loose it is. It's a mobile, this is a regular size eye. So even if it has a big optic, nothing has a 13.5 overall diameter. So here's some vitrectomy from the front. As I said, sometimes you need to start with that, removing vitreous from the area that is going to be working. And then here's using the vitrector in IA cut mode, making the posterior capsulotomy bigger. Now this is, you can see this fibrosed capsule. This is not as easy to get posterior optic capture. So you'll see it's a little bit more work as compared with like at the time of primary cataract surgery. So looking at that capsule opening, the haptic optic junctions are where the places where the IOL will be fixated. And so putting the side that you think is going to go, the side that's going to be more difficult, put in earlier. I thought the far side was going to be more difficult, but the side toward us inferiorly in this view was more difficult. So you can see the capsule's not stretching very much. So there, it's tucked behind. And then in this kind of situation, I'll often need to use a second instrument with the, this is a larger IOL manipulator to catch the capsule edge, and then tuck the other edge, other end of the IOL optic behind. And then here's a little sweep to each side, tire iron sort of maneuver to make sure it's behind. Now you can see, remember that lens that moved all over? Look at how stable it is. That's what it is poking. It was just to test and demonstrate stability. And here is a patient with negative dysphotopsia. And Sam is the one who figured out this anterior optic capture treatment. It's totally, at least to me, non-intuitive why it works, but it does work in a lot of patients. This would have been easier to see if the pupil was a little bit bigger, but this is one where it just I used the small IOL manipulator, little OVD underneath the anterior capsule to lift it. And then using the small IOL manipulator, catching the edge of the optic on each side, lifting it in front of the anterior capsule, and then doing the same thing on the other side. This one's kind of easy because the size of the capsule and so forth, but so it can be a little bit more involved. I think it works 95% of the time. The only notable downside is that if a patient was plano and a third or a quarter diopter myopia is going to drive them crazy, may not be as good an option. But this really works, and it's way easier than a total lens exchange. Now I just pull up the edges if the haptic optic junctions are at 12 and 6. If they're at 3 and 12, I have to open the bag, or I do open the bag and rotate it because I want to make sure that the situation is resolved. Here's just removing the OVD with a manual Cortex aspirator. And so this is a video of what I typically do as a secondary IOL for IOL placement when there's no capsule support. So that was a 7mm wide groove, tunneling anteriorly. This is a 24 gauge angled MBR blade, a very sharp blade. I put a little ink on the shaft, and on the counterclockwise incisions, I make them a little bigger. This is a little bleeding like this happens, I don't know, 20% of the time or something. And I use a cyclodialysis spatula to visually split the eye and then make a mark on the other side and then do the exact same sort of incisions. And the distance back here is just the right distance. In a large eye, it's further back. In a small eye, it's further forward. There's keratome enlargement to the 7mm width. And then this is the one-piece lens, CZ70 lens. And you need to have both of the haptics, both of the suture arms over the top of the haptic, one through the eyelet and the other one between the eyelet and the optic. So I take up the slack as I put that in, slack on the left. Then we'll do a 2-wrap throw here just to hold that in place while, this one I tied off all the way. What I do normally now is just do the 2-wrap throw so that I can check the Purkinje's. 4 single wraps on top of the 2-wrap. This stuff's really slippery. It's 4 fluorine atoms for every 2 carbons. So it's loaded with what is a hydrophobic sort of atom in that molecule. So this is a little shorter piece. I do 7 centimeters for the first, 4 for this, and the mini IOL manipulator, tuck it, put it in through the pupil, then using this is a 25 gauge curved coaxial forceps. So I use a 24 gauge blade, and that makes it easier to get through with the 25 gauge forceps. I push on this side, I push the optic down a little bit to make sure I'm staying over the haptic. The key for any of these sorts of things, the knot has to be inside the eye. The knot in some patients will erode through any flap. Here's good Purkinje images showing that it's flat and centered, and even after some miotic. And actually that's miotic, and then you can see, so I make 2 PIs, maybe 1 millimeter in size. And that essentially prevents that optic going behind, iris going behind the optic. All right. And there people ask me, well, why don't you use, I'll just say the name of it because people, the Acryos lens. It was very popular amongst retina surgeons until they had to start doing their own re-ops or look at the eyes. This is the subsurface calcification that happens in the hydrophobic acrylic IOLs when exposed to air. So cornea specialists like myself are affected by that. Retina specialists who put gas in the back are affected. And this is a patient that was sent to me and said, get this lens out, put the one that you usually use. And I can't see the back of the eye. Retina specialist said that. Okay, so here's a case with where you can see it's a multifocal IOL, not particularly well centered. You can see the capsule's a bit of a mess there. And so putting some OVD underneath and around, and then bring the lens around. And that one of those haptics was sort of in the bag. And then here's using, so this is a 23 gauge trocar, which, you know, the eye needs to be well sealed, because when you do this right here, you really increase the pressure in the eye. So, and here's some subconj anesthetic to get the patient a little more comfortable. In limbal infusion, cannula, self-retaining. Here's, you can see the vitreous right there. You don't need the triamcinolone to see it. Incision here, it's probably 3.5 millimeters. That's about the size, 3.2, 3.5 that I use for refolding. So here's paracentesis on the far side, and then bring the haptic anteriorly, and then we'll put the make the actual incision the rest of the way, and bringing one haptic out through the main incision, cyclodialysis spatula underneath the optic, and then acrylic insertion forceps. So these have been around for a long time, since the early acrylic days, and then bringing that out. It's nice to have something to be able to fold it. You don't have fragments going in the back. That coaxial capsulorhexis forceps I had in there has millimeter marks on. So using a cystotome there to open the posterior capsule, and then this is the capsulorhexis forceps again. And I don't know how many of you have done posterior rexi, but they're fantastic for a lot of purposes like this. The posterior capsule's maybe a quarter as thick. It's 3-4 microns. And so it behaves rather differently than anterior capsule. You have to be more careful with it. And so this is sort of a slow posterior capsulotomy, but this is what you need to do to get a nice result. The zonules for the rest of this capsule were actually good. So I wasn't concerned that, if I fixated to the capsule, I was going to have the whole thing dislocate. It was, most of the zonules were good. As you can see over to the left, not so good, but I didn't need support everywhere. And so there's the completion, then I measure here to decide which IOL to put in. One of these is available in a 6, the other in a 6.5 millimeter, and I fold these. I don't inject these because injecting for regular cataract case is okay if you're using this, but when you've got open capsule, last thing you want is for you to inject it and have one of the haptics still inside the injector or come loose inside the eye. So here's posterior optic capture again. A little bit easier here because it's posterior capsule that's thinner, not fibrosed. Still using a second instrument here to help retract the capsule a little bit. And then we'll pull the IOL optic over and tuck it in. Again, a little bit of tire iron swing to the sides, and that capsule is now in front. You can probably kind of see you can see the oval opening, but you see this IOL is nice and stable. And let's see, I'm going to go, actually, I've got a few more, but time-wise, I think we need to move on to Sam's part so we can try and keep your evening intact here. I'm going to stop sharing, and Sam, take it away.
Greg gave a very, very comprehensive analysis of IOL exchange. So I'm going to limit my comments to basically getting the single piece, let me get to my single piece acrylics out of the capsule bag. Probably one of the chief reasons that we need to exchange lenses today really is for the dysphotopsias or the dissatisfied diffractive optic or premium IOL patient. So we'll concentrate on that. And then if we have some time, I'll make some comments regarding Greg's very comprehensive presentation. So how do we get the lenses out? I do have some disclosures. None of them are relevant to this presentation. And as you saw Greg use, microsurgical instruments are particularly valuable in dealing with lens exchange. So we used to have to steal them or borrow them from the retina people, but we have MST and other manufacturers who provide these devices for us. The other comment I'd like to make before we take a look at how to get the lenses out is I'm a fervent believer in cleaning of the subcapsular LECs at the time of primary cataract surgery so that we avoid this capsule contraction, this fibrosis, phimosis that takes place as a result of fibrometaplasia of the LECs, and particularly when it comes to premium IOLs, because we may have to remove them, then I think it's very advantageous not to wind up in this situation. Now, people have always alluded to the fact that some lenses are more difficult than others. On the left here, you have the Technis Basic model, and because it doesn't have end bulbs, people have felt that they're easier to remove. But actually, when you get up here near the loop optic junction, you've got this very narrow waist and a sharp elbow. And this is a very common area for a fibrotic cocoon to make matters very difficult to remove these lenses. On the other hand, there's a much smoother transition here on the Alcon series of lenses, but here's where you have the end bulb that will cause propagation of this fibrotic cocoon, making each of them particularly difficult in their own way. Let's take a look at some examples. Let me freeze this for a moment. This is a femtosecond spatula. I think it's Eric Donenfeld's design. I use this to get underneath the anterior capsule. Once you're underneath the capsule, you can then place some dispersive OVD or low molecular weight cohesive OVD, depending upon your preference. Avoid the higher molecular weight one. And then once we do that, we then go out and we sweep into the fornix of the bag to help break down adhesions. I then lift the loop optic junction toward the endothelium rather than rotate. And I grab the haptic with a micro forcep. And then I'm going to use a blunt dissection and visco dissection to try and tease open that cocoon. You notice you can have a lot of difficulties there. Once the first one's out, it's much easier because you can then shift the lens over, or you can cut the loop haptic junction. But the concept here is to always tease with visco agent or with a blunt forcep. Go right down that channel to open it up. This is a Technis type device, and this is not well tolerated multifocal lens. We'll try the same things. I'm going to lift here toward the cornea, and as I try and rotate, just as Greg pointed out, I'm watching what's happening to the zonule. I'm looking at the capsulotomy, making sure that that's not moving too close to the center. Some OVD goes down the little channel there. And then I'm going to switch here. I'm trying to peel that fibrotic cocoon away, and I'm not meeting with success. I grab on with a micro forcep and still can't do it. Best thing at this time is to cut the loop optic junction with a micro scissor. And then once the optic is removed, you can either leave that haptic or you can reach into that bag with the micro forcep and lift it out. Notice that cocoon that surrounded that started right at that waist. So be aware of the difference between these two IOLs. Now, once you do that, this is again, assuming the posterior capsule is intact, You want to sweep open the bag with both visco and blunt dissection before you put a new lens in, because there are often fibrotic channels that will cause a new lens to kind of toothpaste tube to the other side. Now, Greg alluded to negative dysphotopsia and anterior or reverse optic capture that we first published going back 2011. When you deal with negative dysphotopsia, if you have the optic in front of the capsule, as Greg indicated, almost invariably it's going to eliminate the symptoms. However, if you have positive dysphotopsia, which is a different animal, you then have to change the optic for one of a lower index of refraction. So here's a patient who exhibited both of those phenomena. And she has here a single piece acrylic toric intraocular lens. So here is the Donnenfeld spatula getting underneath the capsule for 360 degrees. And then lifting that loop optic junction toward the cornea and observing what happens when we try and just swing this out. Now, notice here that I'm watching to see that the bag is not moving toward the center. I notice that optic came out very, very simply. Interestingly, though, this happens to be the inferior haptic nerve. You can see that cocoon wrapped very tightly around that end bulb. Now, I could have cut it and left it, but I prefer to have the bag emptied. And so I'm going to work very hard. Notice I'm working hard enough to stress some zonular fibers as well. But eventually, with patience and blunt and visco dissection, we get that out. Now, removing it, again, you can fold these. You can cut these in a variety of ways. This is an example of where I cut the lens a little more than 180 degrees, rotated it around, and then using these micro scissors, removed the rest of it. And now, because this patient suffered some zonular damage, I'm going to put a CTR just to make the forces equal throughout the zonular apparatus. This is unfortunately a lens no longer available. This is a 3-piece silicone IOL with a round edge, ideal for treating positive dysphotopsia, and a large 6.3 millimeter optic, but not available. I've cleaned the OVD, the lens went in the bag. I've cleaned the OVD from the bag, and now put a little in front so that we can manipulate the optic. I'm putting a spatula behind the nasal side, and then I'm going to lift it up here on the temporal side, so we have now the loops in the bag and the optic anterior to the bag. Now, because the patient started with a toric lens, here I'm going to do some peripheral corneal relaxing incisions in order to correct for the pre-existing corneal astigmatism. And then the OVD is removed under low flow. If you put a high volume or high pressure fluid with reverse optic capture, you're going to pop that right back into the bag, which is not the idea. So a low flow removal. Let's go on to the next. Now, I alluded to this problem before. This is a patient who's had multifocals in for 3 years. She has macular problems, corneal problems, never should have had a multifocal lens, and her BCVA is only about 20/50. Now, we discussed removing the haptics, but you can imagine how difficult it would be also to try and get the optic out from this very, very fibrotic and phimotic capsule. You cannot make a secondary rhexis manually. And so what we did here is I used femtosecond laser, kind of fooled it as to where the gates were. And I'm making a secondary anterior capsulotomy and at the same time correcting some pre-existing astigmatism. So use a micro forceps to peel away the capsulotomy that was cut by the femtosecond laser. And then here are the same steps. Now this lens has been in for 3 or more years. I got the haptics out just as you saw before. And here we'll remove the lenses in bisections. And with this lens, we can really just use a 2-2 incision. Here I'm opening up the capsule bag for 360 degrees. And for what it's worth, even at this stage, I'm going to clean LECs to try and prevent late fibrosis and phimosis. and then we'll replace the lens with a single piece monofocal acrylic lens right back into the capsule bag where the original one came from, and set pressure at physiologic levels and complete the surgery. What I'm showing down here is that we elevated the pulse energy from the default 6 to 10 in order to cut that capsulotomy. And this is what the patient looked like 6 months later. She had an uncorrected acuity of 20/25, where her multifocal acuity was 20/40 at best. So those are the concepts in trying to remove single piece acrylics from the capsule bag. In the interest of time, I'll stop talking here to see if there are any questions or comments that other people might have. So let's stop sharing the screen. Greg or anyone? Vince? You're muted, Vince. You're muted. You're muted.
Thanks so much, Sam and Greg. We're 1 or 2 minutes behind. There's one question here we hope we can get to before we go on to our next speaker, which is, when is it advisable to cut the haptic during IOL exchange? Any risk of leaving it behind for UGG syndrome?
I just typed an answer to that, but the once there isn't pressure on it, if it's inside the bag, I've not seen any situations where it causes UGG. And really the time it's advisable to, in my opinion, to cut it is if you have decent capsule, decent zonules for a new lens, and that you're going to lose that if you keep pulling, and then cut the haptic. But it, as Sam said, it limits the ability to nicely place a new lens if it's in the bag, the new lens. Sam?
Well, I agree. And the most important thing about it causing UGG is to make sure that you cut it far enough into the fornix of the bag so that you have no sharp edges that are sticking out of that opening in the fibrotic channel. But they're a lot easier to remove once you take the optic out. So unless there's a particular zonule issue, I do tend to remove them.
Greg and Sam, thanks so much for that comprehensive talk that you both gave with phenomenal videos. I really appreciate it. If there